In the cardiac monitor, this is how you assess the waveform capnography. This is the waveform that will be coming in the cardiac monitor. In the upcoming exam, as the Norcet level is being more harder, so we'll see more questions that are not common. Hello and welcome to the Excel Nursing Academy. So students, today we are discussing a very important topic for all of you, that is ACLS, Advanced Cardiovascular Life Support. This is a masterclass of ACLS and we'll be discussing the probable question. This is a very important topic for any of your exams, including Norcet mains, ESIC, RUHS, DSSSB, any of the competitive exams. So this will be a masterclass diving straight into the topic. ACLS, what is ACLS? Adult Cardiovascular Life Support or Advanced Cardiovascular Life Support. This is heavily built on the foundation of BLS, Basic Life Support. Often students, they answer BLS questions correctly, but they struggle with ACLS. So ACLS is given by the AHA, American Heart Association, and their guidelines get updated very frequently, nearly every 4 to 5 years. And this is the current algorithm that we are seeing on our screens. So ACLS involve advanced care that we provide to the patient by the use of medications, advanced airway that is usually provided in the hospital, unlike BLS that was given at the time of the injury. So then adult cardiac arrest algorithm, as we are seeing on our screens. So as in any algorithm we see in the BLS also, we have to start CPR by circulation, airway, breathing. CAB, we have to start the CPR, we have to give oxygen, and after CAB we'll go towards defibrillator. We have to attach defibrillator. The defibrillator will assess whether the rhythm is shockable or non-shockable. In the ACLS protocols, the rhythm is either shockable or non-shockable. Shockable rhythms, they will respond to the defibrillators, while the non-shockable rhythms, they will not respond to the defibrillators. Here we are seeing the shockable rhythm. We have VF and PVT, that is ventricular fibrillation and pulseless ventricular tachycardia, while we have non-shockable rhythm, that is your asystole and pulseless electrical activity, which was recently asked in your Norcet pre-exams. Norcet 7 pre-exams. And then the shockable rhythm, we'll see if the rhythm we get is shockable, then we'll deliver our first shock. After delivering the first shock, we'll again resume the CPR for 2 minutes and we'll gain an IV or IO access. IO is your intraosseous access. So the second reliable access that you have to go to after the IV access is your intraosseous access. We will again be assessing whether the rhythm is shockable and non-shockable. If the rhythm is still shockable, you will deliver your second shock. After delivering the second shock, we'll again resume the CPR for 2 minutes. Then is the time for giving epinephrine, which is given every 3 to 5 minutes. The dosage of epinephrine is 1 mg every 3 to 5 minutes. So then afterwards, we'll consider the advanced airways. Advanced airways like LMAs, ET tube, TT tube, tracheal tube, any of that. And then the capnography, that is monitoring the carbon dioxide. Afterwards, we'll again assess the rhythm is shockable or non-shockable. If the rhythm is still shockable, then we'll go towards our third shock. So after delivering our third shock, we'll again resume the CPR for 2 minutes. And then after 2 minutes of CPR, we'll be providing to the patient amiodarone. Amiodarone, or if amiodarone is not available, we will be giving lidocaine. Amiodarone dosage is, first dose is 300 mg and second dose is 150 mg. While the lidocaine dose, as you can see here, the first dose is 1 to 1.5 mg per kg, while the second dose is 0.5 to 0.75 mg per kg. Then treat the reversible causes. If after this patient is still not coming to consciousness, the 3 shocks you have delivered, then you have to treat the reversible causes, which are these. So reversible causes we learn through an acronym, that is your 5H and 5Ts. We will be studying these later. So if the patient does not regain the consciousness after 3 minutes and the rhythm is still shockable, this will keep continuing again and again. And if the rhythm is non-shockable, so for the non-shockable, we'll again be going to the asystole and pulseless electrical activity when the rhythm is non-shockable. So if the rhythm is non-shockable, you have to administer epinephrine ASAP, as soon as possible. Provide 1 mg every 3 to 5 minutes. This is immediate. You have to do it immediately. Then you have to start the CPR for 2 minutes again, and then check for IV or IO access if you need any. While here you have to do this early. Then consider similarly advanced airway and capnography. Then you have to again reassess the rhythm, if it's shockable, if it's non-shockable. If the rhythm is non-shockable, you have to only provide CPR for 2 minutes and treat the reversible causes. While if the rhythm is shockable, then you have to go towards these. the way that you deliver the shock here, you have to again follow this protocol, but it is non-shockable. You have to provide CPR, again check the rhythm is shockable or non-shockable. If the rhythm is shockable, this flow will be followed. If the rhythm is non-shockable, even in this flow, then we go towards our 12th block, which is saying that if there is no signs of return of spontaneous circulation, go to 10 or 11. 10 or 11 is you have to provide CPR. You have to keep providing CPR. But if there is signs of returns of spontaneous circulation, you have to provide post cardiac arrest care to the patient. Afterwards, you have to consider appropriateness of continued resuscitation or not, which is a shared decision that whether to continue the resuscitation or whether to stop the resuscitation. Next, we'll be seeing what are in the blocks. In the blocks here, they have given the CPR quality. CPR quality, they have said that it is determined by whether you push hard enough or not, at least 2 inches or 5 centimeters, and fast, that is about 100 to 120 per minute. And you have to allow the complete chest recoil. Then you have to minimize interruptions in the compressions, and then you have to avoid excess ventilation. Interruptions will be minimized when every ACLS member will know their roles and responsibility well. There will be no clashing of the roles and they will be trained well enough. Then you have to avoid over excessive ventilations. Change the compressor every 2 minutes or sooner if fatigued, because if you are fatigued, your quality of the CPR deliberation will be hampered. If there is no advanced airway, then 30:2 compression ventilation ratio will be continued as similarly. Then quantitative waveform. So waveform capnography or quantitative waveform capnography is monitored, is the reliable method for assessing the ventilation and breathing in these patients. If the PET CO2 is low or decreasing, you have to again reassess the CPR quality. This will be studying in further slides in detail what is PET CO2 and why it is low. Then we have to reassess our CPR quality. Then shock energy for defibrillation they have given. In the biphasic we have 120 to 200 joule. In the monophasic we have 360 joule. Also this will be depending if we do not know what the manufacturer is, what the guidelines is. If this is unknown, we will be using maximum available. Then drug therapy, we said epinephrine IV or intraosseous dose 1 mg every 3 to 5 minutes. Amiodarone IV or IO dose, first dose is 300 mg bolus, second dose is 150 mg. And then if this is not available, we'll be going towards lidocaine. Lidocaine first is 1 to 1.5 mg per kg, second is 0.5 to 0.75. So in the advanced airways, you will be opting for endotracheal intubations or supraglottic advanced airways like your laryngeal airway mask, combi tubes and esophageal tubes, all of them. Then waveform capnography or capnometry to confirm and monitor the ET tube placement, whether you have placed the ET tube correctly or not, that will be confirmed from the waveform capnography. And once the advanced airway is in place, then you have to give 1 breath every 6 seconds, that is your 10 breaths per minute with continuous chest compressions. After you have placed the advanced airways, you can simultaneously give compressions and ventilation. So you have to keep continuing both. You will not then give 30 compression and then stop and then provide 2 breath. No, you will be doing them simultaneously. You will be providing compressions continuously and giving ventilations for 1 breath every 6 seconds. That means you will be giving 10 breaths per minute. Then in this, if there is a return of spontaneous circulation, how will we identify the return of spontaneous circulation? First is there will be pulse and BP in the patient. There will be an increase in both of them. Then there will be abrupt sustained increase in the PET CO2, typically more than 40 mmHg. Then there will be spontaneous arterial pressure waves with the intra-arterial monitoring. This is your return of spontaneous circulation parameters in the PET CO2, in the arterial pressure monitoring, in the pulse and the blood pressure, your usually vital signs. So then reversible causes that we said, there is 5H, 5Ts. First H is your hypovolemia, which is the most common cause of pulseless electrical activity. Then is your hypoxia, hydrogen ions, hypo or hyperkalemia, hypothermia, tension pneumothorax, cardiac tamponade, toxins, any of the overdose of the toxins, pulmonary thrombosis and coronary thrombosis. These are reversible causes. So any of the time if the patient is not completely coming to the consciousness, you have to assess the reversible causes. CABD, that is circulation, airway, breathing and differential diagnosis. Differential diagnosis is by assessing the reversible causes. That is how you assess your patient in a ACLS protocol. Then we said about the shockable rhythms. We need to defibrillate. This is your ventricular fibrillation. This is your ventricular tachycardia. This is your pulseless electrical activity, and this is your complete flat line of the asystole. So these are shockable rhythms where we need to defibrillate, and these are more common. While pulseless electrical activity in asystole, these are non-shockable rhythm. We do not defibrillate. These are more for cardiac arrest among the hospitalized patients. These we see in hospital cardiac arrest, IHCA and OHCAs. This is OHCA is common, and this is IHCA common in hospital cardiac arrest. So pulseless electrical activity, usually we see that the graph is normal, but there will be no pulse, usually due to hypovolemia, excessive bleed and internal bleed, all of those conditions. This is an image based question. If that comes, is this is ETCO2 and this is another ETCO2 parameters. Here you can see the ETCO2 waveforms in the patient. ETCO2 38 mm of Hg, that is coming in the patients. This is in the cardiac monitor, this is how you assess the waveform capnography. This is the waveform that will be coming in the cardiac monitor. In the upcoming exam, as the Norcet level is being more harder, so we'll see more questions that are not common. So this is till now this question has not come, but there is probability that any of these questions may come. So this is a waveform capnography, and this is the ETCO2 of 38 mm of Hg. So now what is waveform capnography? What is all this? It is a non-invasive measurement of CO2 amount in a person exhaled breath. So CO2 amount the person that is exhaling in each exhalation, that this is a measure, and this is non-invasive. And then the normal ETCO2, that is your end tidal carbon dioxide, end of the tidal volume, what the carbon dioxide is, that is the normal is 5% or 35 to 45 mm of Hg. Here you can see the normal range is 35 to 45. The height in the capnograph is the total CO2 that you are seeing, while the length is the time rate. Here you can see this is a normal capnograph going by 45 mm of Hg. This is a hyperventilation which is going very fast, and this is a hypoventilation which is going very slow and taking more carbon dioxide at the end of the tidal volume. Then where we use the end tidal CO2, ETCO2, we use in the anesthesia, we use in the cardiac arrest, and we use it for checking the ET tube placements. So another acronym that you can remember to know where the ETCO2 is used is PQR. So P is for the positioning of ET tube. Usually in the cardiac arrest, the ETCO2 is less than 10 mm of Hg, and after placing in ET tube, the body is then again able to exhale out the carbon dioxide that is retained, and the ETCO2 will rise to the normal levels of 35 to 45. And then is Q, the quality of the CPR. If you are doing a CPR of good quality, then the ETCO2 will be greater than 20 mm of Hg. If not, if it is less than 10, as we saw in the algorithm, see that if the PETCO2 is low or decreasing, reassess the CPR quality. So if the PETCO2 is less or decreasing, you have to again improve your quality of the CPR. So for checking the quality of the CPR, it should be greater than 20 mm of Hg. Then we saw in the return of spontaneous circulation, there was written that abrupt sustained increase more than equal to 40 mm of Hg. If there is a return of spontaneous circulation, there will be abrupt as in sudden, and then sustained. This will keep elevated more than equal to 40 mm of Hg. Patient's ETCO2 will be normal. Moving on are few of the probable questions now we'll be discussing. First is, which of the following component is not included in the metrics of high quality CPR? This was a Norcet 4. This was asked in Norcet 4. And A, chest compression fraction greater than 80%. B, compression rate of 100 to 120 per minute. C, no excessive ventilation. And D, change position every 5 minutes. Answer in this is change position every 5 minutes. Chest compression fraction greater than 80% means the total time that you provided resuscitation to the patient to the time that you provided the compression to the patient, that shall be greater than 80%. So in the total resuscitation time, your chest compression time will be greater than 80% of the total time. Second is your compression rate of 100 to 120 per minute. Third is your compression depth of at least 50 mm or 2 inches as we say in adults, and at least 1/3 the anterior posterior diameter of chest in infants and children. Another is to allow for full recoil after each compression. And the last is there is no excessive ventilation. You have to provide 30 compressions after 2 breaths, 1 breath every seconds. here if there is no advanced airway available. If there is advanced airway available, you have to provide one breath every 6 seconds. So in the question it was asked metrics of high quality of CPR. Metrics are measurable. How do you measure? With the chest compression fraction is greater than 80%, the compression rate of 100 to 120, there is no excessive ventilation. You are providing, if the ventilation, 1 breath every second with 30:2, or with the advanced airway 10 to 12 breath per minute. Then the last is wrong. It is because change position every 5 minutes. You have to change position every 2 minutes, but that is also not a metrics of high quality CPR, though it is advised to do that, recommended to do that to avoid the fatigue in the CPR providers. Another question is, what are the component of the ACLS survey? A. Airway breathing circulation defibrillation. B. Airway breathing circulation differential diagnosis. C. Airway breathing circulation defibrillation. And D. Airway breathing CPR differential diagnosis. The correct answer is B. Airway breathing circulation and differential diagnosis. So ACLS survey means how do we assess the patient in accordance with the protocol of the ACLS. So ACLS suggests your CABD, that is circulation. You have to check for circulation, you have to check for airway, you have to check for breathing, and D, differential diagnosis. We studied that after there was no shockable rhythm, after patient was not gaining consciousness, you have to keep assessing, you have to treat the underlying causes, treat the reversible causes, is what it was written there. So differential diagnosis means you have to check whether the patient is not suffering from any other type of reversible causes that you can reverse by providing interventions to that causes, to specific to that cause. As hypovolemia is a differential diagnosis, so you can treat the patient by providing enough IV fluids. That is the treatment there. So you have to keep checking for the differential diagnosis. And CABD, another, that is the protocol that is for delivering treatment to the patient, that is circulation, airway, breathing, and defibrillation. That is your protocol that you are giving to the patient. This is a survey that you are checking in the patient. Another question is, what is the recommended method to monitor breathing in the ACLS? A. Look, listen and feel. B. Capnography. C. Venous blood gases. D. Monitoring chest rise. So the answer is B. Capnography. In the ACLS protocol, the reliable and the most recommended method to monitor breathing is your capnography, waveform capnography, assessing the EtCO2 and tidal carbon dioxide. Then another question is, if a patient is in a cardiac arrest with a rhythm of ventricular fibrillation, what is the initial intervention? A. Defibrillate. B. CPR. C. Administer the epinephrine. And D. Intubate the patient. So the correct answer is your A. Defibrillation. As soon as you get to know that the patient is having a rhythm of ventricular fibrillation, the initial intervention will be defibrillate. Then there is a scenario based question that a 68-year-old female with a history of atrial fibrillation and hypertension is brought to the emergency department after collapsing at home. She was found unresponsive and pulseless. Bystanders initiated CPR. On arrival, the patient is in a cardiac arrest with pulseless ventricular tachycardia rhythm. What is the most appropriate initial action? A. Administer epinephrine. B. Defibrillate the patient. C. Perform CPR. Or D. Intubate the patient. So similarly, the correct answer is defibrillate the patient. Why? Because it is a ventricular tachycardia, it is a shockable rhythm. As soon as you get to know that it is a shockable rhythm, you go for defibrillation. So scenario keeps continuing that after defibrillation, the patient remains in the cardiac arrest. What is the next step? A. Administer amiodarone. B. Perform CPR and administer epinephrine. C. Administer a second dose of epinephrine. And D. Intubate the patient. So the correct answer is to B. Perform the CPR and administer epinephrine. After, if you remember the ACLS algorithm, you will know that after providing defib, we have to again resume the CPR and then administer epinephrine. Usually we remember it as after each even shocks, that is 2, 4, 6, 8, we provide epinephrine, and after each odd shocks, that is 3, 5, 7, we give amiodarone. So amiodarone is given after third shock and seventh shock, and epinephrine is given after first shock usually. If not, then after second shock, fourth shock, sixth shock, like. The patient is intubated and ventilated. What is the most likely cause of her cardiac arrest? A. Pulmonary embolism. B. Hypoglycemia. C. Hyperkalemia. And D. Coronary artery disease. So the most common cause that we get to know of it is coronary artery disease in the patients. After successful resuscitation, the patient is transferred to the ICU. What is the potential complication of this event? A. Acute kidney injury, B. Stroke, C. Pulmonary edema, and D. All of the above. So the correct answer is all of the above. The potential complication of this event can be anything. The kidney can be injured, there can be a stroke, there can be a pulmonary edema, all of the above. To prevent future cardiac events, the patient should be treated with A. Aspirin, B. Beta blockers, C. Anticoagulants, and D. All of the above. Answer is yours, D. All of the above. A patient is in a cardiac arrest with a rhythm of pulseless electrical activity. What is the most likely cause? A. Hypovolemia, B. Hypoxia, C. Hyperkalemia, and D. Acidosis. As discussed, the answer is A. Hypovolemia. We said that pulseless electrical activity usually occurred from the hypovolemias and the bleeding and all those conditions which are reversible. You suspect the cause of pulseless electrical activity is hypovolemia. What is the appropriate intervention? A. Administer epinephrine, B. Defibrillate, C. Intubate, and D. Administer fluids. So as soon as pulseless electrical activity, you know the reversible cause is hypovolemia. You have to now treat the reversible cause. You have to administer fluids as soon as possible. What does an increasing EtCO2 recording during CPR indicate? A. Effective CPR, B. Ineffective CPR, C. Respiratory alkalosis, and D. Metabolic acidosis. So as we discussed, an increasing EtCO2 will be indicating that effective CPR is being delivered to the patient, while a low EtCO2 will be indicating that the CPR quality is not well. So usually we said it will be greater than 10 to 20 mm of Hg. How can you improve the EtCO2 reading during the CPR? A. By increasing the rate of chest compressions, B. By ensuring the proper airway management, C. By administering a bronchodilator, and D. Both A and B. So the correct answer is both A and B. You have to increase the rate of chest compression. You have to ensure the proper airway management. While giving an advanced airway or anything that will improve the ventilation and breathing in the patient will be opted out. Which method is preferred if intravenous access is not possible? So as we discussed, either it is IV or intraosseous route. So the method that is preferred is intraosseous. Central line insertion we do not prefer because it will take a lot of time and patient will lose a lot of precious time that we can use. And intraosseous is a quick method that absorbs well. This was all in today's class. We discussed what is ACLS, what is its current algorithm, what are the probable questions, what all things you have to keep in mind. I hope you all will have understood this class. And if any questions that you can ask in the comments box, if you still did not understand anything, you can comment and we'll be happy to help. Also, we are available on Instagram. Go follow us there. We have a WhatsApp channel where we post daily quizzes and vacancy update. You can also follow us there. Keep following. You can also comment any concept that you want us to discuss next. Till then, like, share, subscribe, hit that bell icon and stay tuned for more such videos.